Hey everyone, today we're going to explain diabetic ketoacidosis, very important topic that everyone should be aware of, along with diabetes type 1 and type 2, whether for for example, pediatric course or even internal medicine. So let's get started. Before we start, let me just give you a brief physiology on what's going on and what's the pathophysiology of such a disease. Now, let's just imagine there's a glucose molecule here and there is a cell, there's the pancreas, and I'm gonna scroll here and there's insulin. Okay, normally what happens is there's a glucose molecule, and when obviously you eat something especially with carbohydrates, there's gonna be a surge in your glucose level, and when there is an actually high level of glucose, your pancreas will produce insulin, and that insulin will allow the glucose into the cell by obviously, for example, a for transport chain into your cell. Now, what happens is for patients, especially with diabetes type 1, by the way, this disorder can actually happen with diabetes type 2, but more commonly happens with diabetes type 1 only. Now, diabetes type 1 is basically an autoimmune disease. There is progressive destruction of the pancreatic cells. When there is a progressive destruction of the beta cell in the pancreas, there is no production of insulin, and there is no such a way that glucose can enter the cell and actually meet the metabolic demand. So the glucose here will be high because obviously it's not been utilized by the cell. Now the cell will seek different nutritional demand or nutritional source to actually meet the metabolic demand. In this case, it's going to be fatty acid. So fatty acid from from your belly fat or any kind of fat has been deposited as a triglyceride will be utilized by the cell, by the mitochondria, by fatty oxidation, and the waste product of that is going to be keto acids or keto acids. Okay, so you kind of know so far where the name actually came from, diabetic ketoacidosis, because diabetic meaning there's a lot of glucose in your blood, keto meaning there is keto acids in the blood causing high pH, which is acidosis. So diabetic ketoacidosis. So that's basically kind of what's going on in someone's body. Now let's just talk about the criteria, how to diagnose diabetic ketoacidosis. We're gonna go to the name and just make it in three parts. To diagnose diabetic ketoacidosis, you need three things. Diabetic, meaning the patient is diabetic. By diabetes, the random blood sugar gonna be more than or equal to 200. Now some books actually suggest more than 250. I personally follow the 200. Now there is keto and there is acidosis. Now for keto, either ketonuria or ketosemia, which is in the blood. Ketonuria has to be +2. For acidosis, obviously we're gonna follow the pH, which is gonna be below 7.35, or HCO3, which is bicarb, below 15. Now normally bicarb is 22 to 26. Some books also follows 7.3. It depends on what books to actually follow, but usually diabetic ketoacidosis DKA has to have these three components. Now we're gonna talk about how to manage DKA and what actually to follow. Just follow the pathophysiology behind it. As we mentioned, there is a lot of sugar in your blood. Now when there's a lot of sugar in your blood, all of the fluids around the body will actually follow this hyperosmolarity state in your blood. So there's a lot of glucose. Now fluids will actually follow, and when fluid comes, some electrolytes will also come, and it's going to be osmotic diuresis. So you're going to lose fluid and you're going to lose electrolytes. This is very important. Obviously after that is going to be, as we mentioned, ketoacidosis. Basically there's a lot of acids. So there's kind of like two arms to actually think about on how to manage. So you're gonna manage this osmotic diuresis, and also you need to manage the acidosis. Okay, how to manage osmotic diuresis? The fluid, the electrolytes that you lost. Now the most important electrolytes to actually think about, which is potassium, because wouldn't care about anything else, because potassium in specific can actually have cardiac arrhythmias, whether it's low or it's very high. Potassium has to be monitored every hour. Okay, hourly you have to monitor potassium, and also you have to monitor fluid, because this patient has severe dehydration. Now in dehydration, obviously you're gonna give fluids. For acidosis, obviously you can give something like insulin, and you have to give insulin because you want to these glucose molecules into the cell, and obviously insulin also will allow the H to get into the cell as well. So there's going to be low acidosis, it's going to be like fix the acidosis, and also going to fix the high glucose in your body. So insulin is a must here. Also, fluid is a must, as we mentioned, because there's a lot of osmotic diuresis, and also potassium because of cardiac arrhythmia. So these three, you have to work to manage these patients. Now, before we actually talk about each individually, something you need to know, which is classification of the severity of DKA. What I mean by it, if we say this patient has mild DKA, the BH, and also the HCO3. The BH is going to be between 7.25 to 7.35. It's going to be between 10 and 15. Here, if we can mention moderate DKA, is going to be 7.15, 25. It's going to be 5 to 10. If we say it's a severe, it's below 7.15 and below 5. Why is that? Because each category of DKA has to be fixed within amount of time. So if it's a mild DKA, you have to fix it over 24-hour period. If it's a moderate DKI, you have to fix it within 48-hour period or 720-hour period. Why is that? Because we are afraid of the complications that might occur with DKA that we're going to mention soon. Okay, so we're going to start with insulin. You're actually going to give normal, or we're going to get regular insulin, which is the only IV formula of insulin, which is regular insulin. This is the only IV formula. The others are either oral or sub-Q. Now, the rate is important for some of you, which is between 0.05 to 0.1. We call it unit per kg per, and this is very important, per minute, not hour. Okay, now for fluid, you should give bolus normal saline, which is 0.9%. 0.9. Okay, and obviously this is 20 ml per kg per hour. Not per hour, sorry, because this is a bolus. So we're gonna give it instantly. Whereas here, it's actually an infusion, not bolus. Because we're afraid of hypoglycemia. If you give a highly amount of insulin by once, the cell will actually get the H and also the potassium. So if we give higher amount of insulin, there's going to be hypokalemia, and this is very dangerous for the heart, and also will probably result in kalemia as well, which is alkalemia, sorry. So you don't need to actually give insulin very high. You should give it gradually by infusion, okay, by this rate. Now this is bolus normal saline, which is 0.9. You start with a bolus, as we mentioned, 20 ml per kg. Now 4K, you should only give it after the patient pass urine. This is important. So you know the fluid is working. After that, you give, if the patient has below 5.5K, you give him by the rate of 20 mq, which is called milliequivalent. And milliequivalent, obviously, this is per day. After that, the patient will probably, be significantly better than before. So we're gonna switch these kind of emergency drugs into kind of like maintenance. So as we mentioned, insulin is gonna be this for the entire, whether emergency or the maintenance. Whereas the bolus here, we're gonna switch it to either we're gonna continue normal saline or half saline, normal saline. We're gonna give either that or that by obviously a rate 25 ml per kg plus the maintenance fluid minus the bolus you give. So just a quick example for someone who understands what's maintenance is. Maintenance is basically the amount of fluid that the patient needs regularly, and calculated in children 150 20. The first 10 kg is multiplied by 100, the second 10 kg can multiply by 50, the rest is multiplied by 20. So the patient, for example, has 30 kg, his first 10 kg is going to have 1,000 because 100 multiplied by 10. The other 10 kg is going to be multiplied by 50, it's going to be 500. So that the last 10 kg is going to multiply by 20, which is 200. So the patient maintenance is 1,700 ml per day. You're gonna, for example, this 30 here can multiply by 85, plus the maintenance minus the bolus. It's something that really needs to understand fluids, but it's kind of very advanced. Regardless, we go to potassium here. In potassium, as we mentioned, you're gonna be just monitoring every hour and with ECG obviously, and if it's below 0.5, just give it. If it reaches below 3, stop. You don't give it. You have to stop potassium here. Okay, so these kind of the things that you actually like just work about. Now there is complication, and this is very important to understand, the complication of DKA or the management of the DKA, by the way. One of the complications that might occur with DKA is something called cerebral edema. So let's just imagine there's a neuron here, or just like the brain tissue, and there is the blood here, and we said there's a lot of glucose, right? Now normally when you give a lot of fluids, and that's why we're very cautious about fluids, but if you give a lot of fluid here, there's a lot of fluid, the Na here, the concentration of Na is going to be very, very low because you give a lot of fluid. There is a dilution of the Na, dilution of the salt. And by physiology, osmosis is basically you go from the low to high osmolality. So the fluid here, which is the white thing, gonna go because he's low and there's high of salt. It's gonna follow from low to high. So the fluid gonna enter the brain tissue and swell. And this is called brain edema or cerebral edema. And I like to memorize it as high to low. Your brain will blow. Your brain will blow. Sorry. So what I mean by it is basically when you fix the high osmolality to low, your brain will blow. Okay? From low to high, your bone time will die. Obviously, this is a complete different thing, but high to low, your brain will blow. Okay? So that's everything you should know about DKA, basically the criteria, the complication that might occur, which is cerebral edema. Obviously, there's a lot of complication from hypoperfusion. For example, kidney injury. For example, pancreatitis. For example, ischemia of the bowel. This is like just a normal thing because there's hypoperfusion. But the most concerning one, which is cerebral edema. High to low, your brain will blow.